Good morning. Okay, good morning, everyone. Welcome all to this Pfizer sponsored symposium titled The Glimpse of Glistening Solution for Multi-Drug Resistant Organism Infections in Asia. So, I am Balaji Veeraraghavan, Professor of Department of Clinical Microbiology, Christian Medical College Hospital, Vellore. It's my great pleasure to moderate this session, The Glimpse of Glistening Solution for Multi-Drug Resistant Organism Infection in Asia. I know it's the need of the hour. You all agree that every day in our routine life, this is a pressing problem we face, and we wanted to listen to the solution. We want to know the solution. Next slide, please. The objective of this morning's session is to share the latest data and current practice of managing multi-drug resistant organism infection. Second, to provide an interactive platform to discuss optimizing outcomes of patients with multi-drug resistant organism infection from diagnosis to treatment. And the third objective of this session is to share the personal experience, day-to-day experience on the gaps and practical challenges the physicians faced in managing the multi-drug resistant infections and the strategies to overcome this MDR-XDR infections. So with these objectives in mind, I would like to have two expert speakers for this session. One who will be talking about the gold standard, that is the ideal way to manage multi-drug resistant infection and the role of novel antibiotics available by Dr. Tobias Welte from Germany. And the second speaker will be the other side of the story. That is, it's not the ideal, the realistic way of handling things day to day. The current landscape and challenges in managing multi-drug resistant organism infection in Asia by Dr. Asok Kurup from Singapore. Then after the experts talk, we would like to listen to the panelists and discuss the reality and the filling the gaps, that is the Fireside chat, contribution to the practical consideration and solution for multi-drug resistant infection in Asia. So this may last for 25 minutes. Subsequently, we will move to the live audience question and answering session. I would like to emphasize here to the audience that anytime during the session, if you have any questions, please feel free to open up the Q&A box, type and then send, so that we will have an access to your questions. Appropriately, we will ask the panelist to answer your question. Feel free throughout the session, during the expert talk, during the fireside chat, and as well as during the question and answer session, feel free to raise the question. Next important announcement what I have is, it's very important to have the feedback from you all. So there are two ways of giving your feedback. One is you can click open the chat and there will be a pop-up web where you can post your questions. The second option is scan the QR code and give your feedback. So with this, now I would like to go ahead and introduce the first speaker, Tobias Welte, to talk on ideal way to manage MDRO infection and the role of novel antibiotics. And I would like to introduce, I will take this honor to introduce Dr. Tobias Welte. He's a very well accomplished person and is currently the professor and head of Department of Respiratory Medicine and Infectious Disease at Hanover Medical School in Germany. He is also directory board member of the Biomed Alliance and president of the Forum of International Respiratory Societies. Professor Welte was earlier president of the European Respiratory Society and German Society for Pneumonology and received the Balzan Prize for Medicine in 2019. His research focuses on epidemiology, diagnosis, and management of respiratory infections and pathophysiology and the treatment of obstructive airway disease. He has around more than 1,000 publications in the peer-reviewed journals and has contributed to the chapters over 150 in numbers. So he's from his track record, you can see his expertise in this area. I welcome Dr. Tobias to talk about the ideal way to manage MDR infection and role of novel antibiotics. Please, Dr. Tobias.
Thank you very much for this very kind introduction. It's a great pleasure to be here and to give this talk about the gold standard of management of MDR infections and the role of novel antibiotics. As you heard, I'm Tobias Welte. I'm the head of the Department of Respiratory Medicine, Infectious Disease in Hanover University. Here are my conflicts of interests, and as ever, a disclaimer has to be presented. If you look to a resistance pattern worldwide, and I only show you two, which are mostly threatening carbapenem-resistant Enterobacteriaceae, so E. coli and Klebsiella is increasing worldwide. In Europe, it's mainly in Southern Europe, in Italy, Greece, and on the eastern part. But in Asia, and I showed you pictures from China, it's very, very quickly increasing, even there are differences between different countries. And more threatening, we have a dramatic increase in carbapenem-resistant Acinetobacter infections, and as you can see, it has spread all over Europe, and only the northern parts of Europe and Germany has lower numbers, but in the south, in the east, and also in the Asian countries, it's a very dominant pathogen. So it's quite known that multi-drug resistant bacteria increases morbidity and mortality. And as you can see here from a meta-analysis, there is a twofold increase in mortality when multi-drug resistance appears. So the strategy to overcome multi-drug resistance is one of the most important in our times. Before I go into the treatment, I want to spend very few words about diagnostics. And I think one of the most important issues is to identify multi-drug resistant pathogens as early as possible to allow targeted treatment of these pathogens. And one of the present technologies is the PCR technology, which is fast, which can be made on bedside, and which shows you the most important and best known resistant pattern. However, for me as a pneumologist, one of the disadvantages is that there's no quantification, and mainly in the lung, it's hard to distinguish between colonization and infection between bugs, which had to be treated and which only have to be observed. Here, one of the papers looking to one of the new, the MDRO technology, and demonstrating that there is a dramatic increase in pathogen detection if you use such kind of diagnostics. And this is a classical paper from Jean-Louis Visson, published in Critical Care, and demonstrating that there is acceptable sensitivity with this technology. Well, this is not the future. The future in my mind is whole pathogen sequencing, and the advantage of whole pathogen sequencing is that you get information about the bug, the resistance patterns, and also the pathogenicity, and this will change our treatment options by far. There are first data, these are one from Fraunhofer in Stuttgart in Germany, demonstrating that there's a dramatic increase in the diagnostic property, and there will be a future which is not only the classical 16S RNA technology, but shotgun metagenomics, and the Asian countries are very much ahead to bring this technology to bedside. So in future, we will have a quicker and better insight into resistance pattern. So what I want to show you during the next minutes, and I want to focus on pneumonia because This is the most important nosocomial infection and most important for multi-drug resistance and gastrointestinal infections because of the high mortality. What I want to show you is a very sophisticated treatment approach with regard to the resistance patterns. And this is the classification we use today. We look to the kind of resistant genes, whether it's a serine or metallobeta-lactamases, and try to focus the treatment to the resistance pattern. And this is a very nice paper published last year demonstrating how this could look like. And as you can see, for different pathogens, there are different new antibiotics available which could overcome resistance pattern. And I will show you data for ceftolozane, azobactam, for ceftazidime avibactam, and for cefiderocol. This is a big ceftolozane tazobactam study, the aspects study, which had been published in Lancet, and in comparison to the gold standard, which still is meropenem, it could be shown that either for ventilator-associated pneumonia and ventilated hospital-acquired pneumonia, there is a non-inferiority to meropenem, and this is in terms of clinical cure, but also in terms of mortality, and this can mainly be shown for Pseudomonas in terms of Enterobacteriaceae. Ceftolozane seems to be a little bit worse. And one of the major challenges in treatment of MDRs is that the current combination treatment using colistin or aminoglycosides has a side effect of acute kidney failure, and this is not present as shown in this work with ceftolozane tazobactam. If we look to Enterobacteriaceae and mainly carbapenem-resistant Enterobacteriaceae, I have to mention ceftazidime avibactam. And you can see a big study portfolio has been done for this substance using the same dosage, 2.5 grams every 8 hours in all studies. And I will go through the studies in detail very quickly. This is the study portfolio for intra-abdominal infection comparing Cax-Avi plus metronidazole with meropenem, and the major endpoint was non-inferiority. As you can see, a huge number of patients had been included, and as you can see here, the non-inferiority margin was reached for all clinical endpoints at all time points. One of my last studies is this one, the REPRAISE study, and I will tell you why. This is a study in ceftazidime-resistant bugs. So you use ceftazidime with the new beta-lactamase inhibitor avibactam in pathogens which normally do not react to ceftazidime. And in this study, it has been shown that adding avibactam to ceftazidime overcomes the resistance patterns and make this combination very effective. And then the main study for pneumologists, REPROVE, again, Cax-Avi versus meropenem, a huge number of patients with nosocomial pneumonia included, and either for the IDT and the clinical evaluable population, the non-inferiority margin could be reached, and this is true either for ventilator-associated pneumonia and for non-ventilator-associated nosocomial pneumonia. And you can see for all Enterobacteriaceae, but also in a less effective way for Pseudomonas, Cax-Avi worked. My last slides with regard to new antibiotic, which is a real development, the first computer-designed antibiotic, a so-called siderophore cephalosporin. And the fancy issue with this is that these antibiotics use the necessity of pathogens to use iron. Iron normally is transferred from the bacterium itself into the cell, and in this antibiotic, iron binding side chain had been added, and so the cefiderocol is transported into the cells, bypassing the cell wall resistance mechanisms by the bacterium itself. And as you can see, the minimal inhibitory concentrations for a number of very difficult to treat pathogens is high. And here we have a pneumonia study too, cefiderocol in comparison to meropenem again. And as you can see here, for all of the pathogens studied, it was an effective drug. However, in a real world study, the credible study, cefiderocol did not do so good as it was in the randomized controlled study. So to conclude, multi-drug resistant pathogens are one of the major threats of the future. They are responsible for morbidity and mortality. Resistance patterns are increasing. We need new and effective antibiotics, and we have some, mainly ceftazidime avibactam for the Enterobacteriaceae is a step forward. However, antibiotic stewardship is a key issue to individualize therapy and not overuse these new antibiotics, because overuse always is followed by more resistance. With this, I want to thank you for your attention, and I'm open for the Q&A later on.
Thank you, Dr. Tobias Welte, for an excellent presentation, presenting with the latest scientific evidence for a therapeutic choice in the MDR time. So it was an excellent presentation. Now I move for the next talk. Before I moving to the next talk, I would like to remind the audience that if you have any question for Tobias, please feel free to enter the question in the chat now. And I will move to the next session. Now it's my great honor to introduce Dr. Asok Kurup. Dr. Asok Kurup is a consultant with Infectious Disease Care Private Limited at Mount Elizabeth Medical Center, Singapore, and visiting consultant at the Department of Infectious Disease, Singapore. Committee member at the Society of Infectious Disease, more than 40 papers in the international journals and 70 abstracts in the field of infectious disease. Dr. Asok, please.
Thank you, Professor Balaji. Can you hear me? Okay, all right. I'm going to shift gears a bit, and I'm going to talk about the current landscape and challenges in managing multi-drug resistant infections in Asia. These are just my disclaimers. So the Asia-Pacific region is highly vulnerable to the threats of antimicrobial resistance. The problems in this region are tremendous, and it includes the fact that there are densely populated cities that can serve as huge reservoirs for the spread of drug-resistant pathogens. Some of these cities have unplanned urbanization with poor sanitation, as well as suboptimal wastewater management. Air pollution can sometimes cause respiratory infections that are often mistakenly treated with antibiotics. There is also a lack of standardized, consistent data with regards to antimicrobial resistance in the region, as well as inconsistent reporting processes. Many laboratories have limited infrastructure, expertise, as well as lack of quality assurance. Clinicians frequently prescribe antibiotics without the support of microbiological results, And diagnostic specimens are unfortunately sometimes submitted from patients in whom empiric treatments have failed. There's also a shift in terms of demand, increasing demand, for example, for animal protein, and a shift to large-scale farming, for example, in parts of China and in India, is driving the use of antibiotics in the agri-veterinary industry. There's also an increase in purchasing power and access to antibiotics, including new and second-line antibiotics that can be quite expensive. And let's talk about antibiotic stewardship. It's practically non-existent in many healthcare institutions and settings, let alone in the animal health and wastewater settings. And very often, antibiotics are taken even without prescription, and the data says it's approximately 9% to 62% in the Asia-Pacific region. We also have an aging and a graying population, as well as immunocompromised populations from the result of care, etc. And these more vulnerable sections of society are correspondingly prescribed more antibiotics. So whether we like it or not, we are actually part of an inner sphere of this concentric milieu of antibiotic resistance, if you will, where we, in terms of the provider, the patient, antibiotics, and the pathogen, may be working alone and in silos, and we don't realize that any of the actions that we do within this inner silo has actionable consequences and have impacts both at a hospital level as well as a population drivers of resistance, and that can potentially catapult antibiotic resistance to what it is today. There are high levels of ESBL producers in Asia. This is Yohei Doi's paper in 2017 to tell you, if you can see already so clear, that in the Asia Pacific, India, China represented with endemicity of more than 50% for clinical E. coli isolates. As for carbapenem resistance in Asia, this is a paper published in 2019 that talked about carbapenem resistance amongst Klebsiella to be high at approximately 5% in at least 4 nations, Indonesia, Philippines, Thailand, and Vietnam, and carbapenem resistance amongst E. coli to be high in 2 of 7 nations, that Indonesia as well as Myanmar. The most common carbapenemases encountered in this paper was NDM as well as OXA. Now, despite sparse data, polymyxin resistance was documented in 8 of 11 nations, with the MCR1 being the predominant genotype. Now, the authors were concerned and they described widespread presence of carbapenem and polymyxin resistance that could potentially be a problem in the continuing risk of the threat of infections that can be resistant to both of these classes of drugs. So this is a graphic to tell you about carbapenem resistance in E. coli. And I think you can see where it is in orange, that the prevalence is more than 5%, represented by Myanmar and by Indonesia. And that of Klebsiella, now it becomes a bit more prevalent with resistance, not just in the higher settings in Indonesia and in parts of Indochina, but here we are in Singapore and Malaysia as well, having rates of about 1 to 5%. But if you track trends of carbapenem-resistant Enterobacteriaceae by regions, you can see this paper, it's approximately 3 years old, but you can see that there's been a trend, at least since 2016, that the rate seems to be still going up in Asia. That's actually represented in the lighter blue. And what's also going up as of 2016 was in Europe, whereas it seems to be coming down in the North American region. As for multi-drug resistant Pseudomonas aeruginosa, the Asia-Pacific region, we have approximately 20% prevalence, and this is data accrued from 1997 to 2016. So we have a hub of all kinds of multi-drug resistant pathogens. And as for mortality, there's a lot of data in this regard as to the consequences of having such MDROs. I just picked a couple. One is patients in 10 hospitals across India with MDR and XDR bacteria were 1.5 or 2.65 times more likely to die as compared to similar susceptible infections. In Thailand, about 43% of deaths in 9 hospitals were attributed to healthcare-associated infections implicating multi-drug resistance. So there is all that kind of urgency around the kinds of multi-drug resistant organisms that we have. And let's just take a clinical setting that you and I may have to manage, which is like pneumonia. But there are massive clinical challenges all the time that we as clinicians face, because what do I do? Should I treat the patient empirically? Do I know that this is pneumonia for sure? Or could the infiltrates in the lungs be due to something else? How sick is the patient? How broad spectrum should you actually cover in terms of antimicrobials? Do you know your institutional antibiogram? What's the bug? Can you even get a sample? Or maybe the culture is negative because you have already given your favorite drug. Or you might be dealing with pathogens, you're not sure whether they are colonizers or not. And then what do you do with polymicrobial growth? Further, how long do you treat? And so these are many of the kinds of uncertainties that we continue to face. So we want to try to improve our care of multi-drug resistant infections and so on. So I think that there are many things that we have to continue to work together in Asia to try to better understand a few things. One, who amongst our patients are at risk for multi-drug resistant infections? So here's the challenge, because we have to understand our own local ecology by way of what is happening in our own institution, in the region, locally, maybe also overseas. So that's a kind of a challenge all the time, because you have to make sure that you have appropriate infrastructure by way of the laboratory, that you have good setups, you have expertise, you have access to rapid diagnostics that was alluded to earlier by Professor Welte. And many of these things are evolving science, and it's good, but in all not settings across Asia, as I alluded to earlier, we have challenges. So we also have to have good antibiotic stewardship programs, which actually is a bit of a problem, and we can talk about that later, as well as access to better antibiotics. So I'm going to end my presentation with a question to all of you. You have a 69-year-old male who has a past history of diabetes, dyslipidemia, renal impairment, and hypertension, who's got recent abdominal surgery for a complicated intra-abdominal infection. The ICU stay has been prolonged for more than 10 days, and the individual has received intravenous piperacillin tazobactam, followed by meropenem and annulafungin now for 5 days. The patient is intubated and mechanically ventilated, but becomes septic and develops ventilator-associated pneumonia. Now, what is your usual practice? Your usual practice may not be the right way, but it may be the right way for you. With regards to antimicrobials in this case, that I use rapid diagnostic tests, or RDT, to direct antibiotics. B, I don't have access to RDTs. I will add my favorite linezolid or vancomycin pending culture. Or C, I don't have access, but I will add polymyxin B or colistin pending culture. D, I will be directed by my institutional antibiogram. E, I will consult my ICU or antibiotic stewardship pharmacist if any. F, I will refer to ID unless you are the ID, or you would do something else. So can I ask you to vote, please? Well, I'm trying to look at that across, and I can see that a variable number, sorry, the font size is a little challenging, and I'm kind of elderly myself. So I think that a lot of people are referring to ID, so we are checkmated, I think. I will be directed by my institutional antibiogram. So for the people in the audience who cannot see, yeah, okay, I don't know, everyone can see this, okay, fine. All right, so there we go, all right. So I think most people have, only 20% would want to use RDTs. Okay, that'll be interesting. All right, so food for thought, and I will now hand it back to Dr. Balaji to continue with the fireside chat. Thank you.
Thank you, Dr. Kurup, Asok Kurup. It was an excellent presentation, and you have narrated the reality that's happening in Asia. So now I wish to move on to the next session, that is the reality and filling the gaps, fireside chat. Now we are going to discuss the practical consideration and solutions for multi-drug resistant organism infection in Asia. I invite Dr. Tobias Welte and Dr. Asok Kurup to discuss the practical consideration and solution where day to day, when we get into a situation like what a few seconds ago Dr. Asok Kurup has raised. So it's in theoretical, it's very easy to talk, but in practical day to day, it's challenging. So we wish we will discuss for some time the day to day problem which we face. And also I would like to invite the audience to share their challenges they face every day in the clinic by opening up the chat and putting their questions into the chat box. Dr. Tobias and Dr. Welte. So I have a few questions for you. So I can start with the first question. Dr. Tobias and Dr. Asok, feel free to answer the question. How can we strike a balance between the use of novel antibiotics and AMR? I know Dr. Tobias just a few seconds earlier has mentioned that he wants to reserve the novel antibiotics and don't want to misuse and overuse and lose its efficacy earlier. So he wants to preserve for longer.
Balaji, in my mind, the main problem is if you overuse antibiotics, you will cause new resistance. So we have to be very careful, but we need these antibiotics because they drop down morbidity and mortality. And one of the major challenges of the future is we are more and more individualized. So looking to the pathogen, looking to the patient with our treatment. In my mind, there are two consequences. First, we need a better education in infectious diseases for everybody working in a hospital. So we need something, we call it in Germany, an antibiotic driver license, which everybody needs to have a yearly education in antibiotic usage. So better knowledge for everybody. And the other issue is we need the antibiotic stewardship teams. The antibiotic stewardship teams for problems in infectious disease management, mainly multi-drug resistant pathogens, are very important. And I was very happy that in the poll, Ask My Antibiotic Stewardship Team was the one which was highly voted. So I think we have to establish antibiotic stewardship teams in all hospitals and make them usable for all doctors in the ICU and dealing with infectious disease patients.
Thank you, Dr. Tobias. Dr. Asok, would you like to say?
Yeah, thank you, Dr. Balaji. And I echo a lot of the sentiments mentioned by Professor Welte. I think one of the challenges in Asia is that we don't have enough access to antibiogram, local institutional antibiogram, access to regional antibiogram, and also the problem with lack expertise is quite acute. Even in some settings where you think that you should be having such great expertise with microbiology, you find that it's actually quite acutely lacking. And we are only as good as what is reported in the laboratory. And if the laboratory does not have good quality assurance, then I don't think we are doing our job right. And we cannot just be giving everyone broad spectrum antibiotics and so on. So I think the most important thing for us to know is what is your local ecology and are you actually seeing such resistant organisms or not? So if you're not really seeing a lot of resistant organisms and you have got pretty susceptible ones, then you don't really have to use a lot of these novel antibiotics. You can reserve them, you don't even have to bring them in because if you don't have a problem, but you really need to make sure that you have that critical expertise to make sure that is actually the case. Otherwise, it may be swept under the carpet. That is kind of where I think I'm trying to underscore the importance of getting laboratory expertise, and I can't say this enough. And even say if you have that laboratory expertise, I just want to reiterate that issue, and I'm glad the poll actually showed that a lot of people are thinking about antibiotic stewardship, because as I alluded to in my discussion, there is very fundamentally lacking in many settings. And so we don't have that kind of access even in many settings. that we think we should, but still it is something that I think should be looked into in the future, and we have to be guided, because when we use when we use rapid diagnostic tests, we have to actually use it in conjunction with antibiotic stewardship. It cannot just be used unilaterally by all physicians, because they will start to treat everything sometimes. And some of individuals who see a new toy and say, oh, so many things have been amplified, let's treat everything. Now that's wrong. And so you have to kind of put that in the context of knowing your institutional antibiogram, you have good lab expertise, have stewardship, then you can kind of tweak in where the novel antibiotics may. So if you do have a problem and you have, say, a large, critical component of your patients have drug resistance, etc., then you can actually place such an antibiotic up front, because we don't want to lose patients as well. And we do know the data is quite telling that if you waste valuable time, you may lose the patient. I actually have some slides. I'm not sure if I can show it at this point. Is that showing up?
Go ahead, Asok.
Is it?
Next slide, please.
Oh, is this the one that's coming? Okay, here I just wanted to tell you about how we identify our risks for patients. Here's data from Singapore with regards to risks for carbapenem-resistant Enterobacteriaceae. It may not be the same for other settings, but here we have male, gender, ICU stay, and hospitalization in the preceding year. I mean, this is in the context of trying to identify who amongst your patients are at risk for multi-drug resistance. So this is just a case example of what happens in different settings. So you can choose your own methods, have your own studies to look and see if that works. The other thing, and this I alluded to earlier, even if you know that, it's very important that you start antibiotics on time, because otherwise you're going to have a lot of catastrophe and you have high mortality. And the other aspect is with regards to mechanisms of resistance, because this is, I think, when people talk about carbapenem-resistant Enterobacteriaceae, when you talk to people who are non-ID, non-microbiology and diverse backgrounds, they don't understand. When they see CRE, they don't know about carbapenemases, non-carbapenemases methods of resistance as well, like the porine channel losses or efflux pumps. They only think in one way. So you have to kind of educate your hospital colleagues and so about where it lies, how you can actually use some of these novel antibiotics better, because when you try to amplify the resistance mechanisms of resistance, you know where to place some of these novel antibiotics. So you need to actually get the right balance. And I'm not sure if I'm eating up into some of your questions, Professor Balaji.
No, excellent. These are all the important clinical pearls which you are sharing, which is need of the time.
Yeah, so one of the things we need to do is to actually make sure that whatever we do in terms of early antibiotic therapy to hopefully improve patient outcomes, but at the same time reducing that ecological collateral by way of resistance and by way of costs as well. And one of the things we can talk about is rapid respiratory panels. And here's an example which is called the BioFire Film Array Pneumonia Panel. Professor Welte has alluded to some of these things as well, because here I'm not sure if it comes out in what you can see, but not only certain types of bacteria, but also the resistance mechanisms, and that can direct specific antimicrobial therapy, because some drugs, certain novel antibiotics, say for example ceftazidime avibactam, we know that that would work for resistance that has got KPC as well as OXA. However, people have to know that all these panels are not comprehensive. There are some organisms which are not represented in these respiratory panels as well. And I think this has been alluded to. There are several studies like this talking about how impactful it has been in terms of being consistent in its positive percent agreement with standard cultures in terms of rapid diagnostics and usual standard of care. This is too busy a slide, but I'll just tell you that for ventilator-associated pneumonia, rapid diagnostics have played a role as well. And this particular paper published, I think, last year in Critical Care talked about how this particular institution used it meaningfully, and they could de-escalate quite a number of cases that did not warrant a lot of antibiotics broadly upfront. But when we do antibiotic stewardship, rapid diagnostics, here's an example, one of the best examples where rapid diagnostics showed better mortality rates. Because you want to show that, but this is not for respiratory samples, this was for bacteremia. And it showed that on your left, you can see that without antibiotic stewardship, the use of rapid diagnostic did not impact meaningfully on mortality. But once you actually coupled it with antibiotic stewardship, the mortality rates reduced. So this is one of the classic examples of where we can go with this kind of technology, but married with appropriate expertise. So we can rationalize these rapid panels, and maybe this is too small a slide to show, but then, this study actually examined the impact of antibiotic stewardship-driven algorithm incorporating rapid diagnostics into the management of gram-negative bacteremia. And this proposed algorithm had resulted in about 88% of cases receiving antibiotic therapy versus about 78% by standard of care. And what they could show was, using specific antibiotics in this stratified algorithm according to the kind of amplified genetic mechanism of resistance. But I just wanted to spend a very few seconds talking to you about the good, the bad, and the potential value of these rapid panels, because the good is that they are fast, and we want it fast. We want one test which is comprehensive and easy to perform. And we detect culture negative infections, but the bad is that, it's a poor quality specimen. For culture, it's a poor quality specimen for PCR. So you only get what you look for. It's not a standalone test because you need phenotypic susceptibility. And its potential value, I feel, is for high negative predictive value for on-panel organisms. And it's got a significant value for the negative, antimicrobial de-escalation. And antimicrobial escalation in infection prevention when resistant markers are detected. And I have some more, but I think maybe I'll go on to other discussion points.
Sure, Dr. Asok. It's very well said. So now I will move on to the next question. Question number 2. What is the optimal positioning of ceftazidime avibactam in current clinical practice to maximize patients' benefits without posing an impact on future emergence of new multi-drug resistant organisms? That is antimicrobial stewardship, right time, right dose and duration, and when to choose appropriate therapy as a first-line therapy or second-line therapy, and how to fill in the exist gap to achieve this optimal positioning in Asian countries, specific for Asia. So I wish to answer certain points for this question. Next slide. So most important, in the previous slide, Dr. Asok said that the newer available beta-lactamase inhibitors are much more better than the colistin usage. So now I would like to mention certain evidences why we should move from colistin and latch on to novel beta-lactamase inhibitor. I'm very impressed with the Singapore that they avoid to great extent the colistin. Look at the current systemic review and estimated rate of nephrotoxicity in patient treated with polymyxin B or colistin. You can see from these figures, almost you can see that colistin here in the last 2 rows, in the last column, almost 40% of the individuals who have taken colistin or polymyxin B, 40% had nephrotoxicity. And it's very interesting to see that even mild cases of colistin associated nephrotoxicity have been linked to a variety of adverse outcomes that includes increased in-hospital mortality, length of stay, need for renal replacement therapy, and increased healthcare resource utilization post-discharge. So I don't think that this is a right choice using colistin. It's more having an ID position antimicrobial stewardship. Our ideal and realistic aim is to avoid colistin or polymyxin B because it doesn't serve the purpose, it defeats the purpose of antimicrobial stewardship. Why we should avoid polymyxin? Already the black box warning for polymyxin is there. you can look at the current scenario, the cutoff, the breakpoint interpretative criteria is available only for Pseudomonas aeruginosa and Acinetobacter species. It's not available for Enterobacteriales. It is only the wild type strain cutoff is present. And it's only calls as intermediate or resistant. There is no susceptible breakpoint. To simply say that limited clinical efficacy of for isolates MIC less than 2. Though you call it as intermediate, you are not certain that it's going to work. When we call it as susceptible, at least 90% of the time, you are sure that it's going to work. When you call it as intermediate, you are not sure at what percentage it will work. Success is there. So there is a lot of ambiguity is there. That is the reason why the CLSI has given warning and comments saying that the clinical outcome and the PK/PD is having very little support for the clinical colistin usage, and they advise the IDSA guidelines and the CLSI guidelines recommends to consider alternative to colistin when it's available. And definitely, very clearly, the message has been sent to across various countries that systemic administration of the colistin for pneumonia cases, lower respiratory infections are not advisable, and it's totally not effective. So now we will look at the new beta-lactamase inhibitor, ceftazidime avibactam role. Next slide. So this has been approved for complicated intra-abdominal infection, complicated urinary tract infection, and it's recommended for hospital-associated bacterial pneumonia and ventilated-associated bacterial pneumonia. However, in India, we do use, I hope in most of the countries, they use off-label for the bloodstream infection. It's not only for the primary bloodstream infection we do use for secondary bloodstream infection, secondary to the catheter-associated bloodstream infection. We do use for osteomyelitis, mediastinitis, endocarditis, ventricularitis. So there is a huge lot of off-label use in day-to-day we have used and had found successful. And here it's been given as a 2 gram plus 0.5 as a 2-hour infusion. Actually, the ceftazidime binds with the penicillin binding 3, and the avibactam is a novel diazo bicyclooctane, which has gotten a dual action. One is it acts as an inhibitor, beta-lactamase inhibitor, and second one is it has an action of enhancer of the ceftazidime. This dual action inhibits the ESBL, AMPC, and it overcomes the porin loss. It inhibits KPC, the carbapenemase, and OXA48 carbapenemase to great extent, and no activity against metallobeta-lactamase and the OXA23-24 produced by Acinetobacter baumannii. So wherever it is found good, I think we should use without any reluctancy. I would like to mention about its role against OXA48. This is an enzyme which is quite, it's more prevalent in Asian countries, where in Europe and America, it's the KPC, in India, it's OXA48. And you can see the MIC evidence, in vitro evidence, that if it is only OXA48 or OXA48 plus ESBL or OXA48 plus ESBL plus AMPC, the MIC 90 is more than 1. It's less than 1 and 1. So the susceptibility probability is really great, above 90% and almost 99 to 100%. It's quite effective. So with this background, what is the real world experience shows? It really shows a superior advantage with the beta-lactam inhibitor, that is ceftazidime avibactam. You can look at these 2 graphs which I have shown you here. The percentage of clinical success and the percentage of mortality in KPC producers. In the top figure, the ceftazidime avibactam, the percentage of clinical success is 85% when it is compared to carbapenem aminoglycoside combination or carbapenem colistin combination and other combinations. It's way superior compared to any other combination therapy available for KPC. And in terms of mortality, again, you can see a greater, sorry, can you go back previous slide? Okay, again, in case of mortality, you can see the great advantage with ceftazidime avibactam than alternative therapy. Both in US and Italy, they have documented the great advantage of ceftazidime avibactam for KPC producers. Next slide, please. Okay, in case of mortality, again, ceftazidime versus colistin, you can see here in this picture, almost the ceftazidime avibactam group had only 9% mortality, whereas the colistin had 32% mortality, 3 times higher than the ceftazidime avibactam. And unfortunately, in the study, they have never had OXA48 or NDM. It's predominantly KPC. However, in Asia, we do see more of OXA48. The good news is, so far in the literature or nowhere in the social media or anywhere, the resistance for OXA48 from the ceftazidime avibactam has not been documented nor seen in the clinical experience. It's a really great good news. And this is the slide which shows the experience only with OXA48. You can see excellent clinical cure with ceftazidime avibactam with 14 days survival and 30 days survival. And recurrence is there for 11%, but definitely there is no resistance for OXA48 has been reported. So for Asian countries where the KPC is not there, it is an excellent choice for OXA48. As Dr. Asok is mentioning, it's very imperative for us to identify the causative carbapenemase enzyme. And if it is OXA48 or KPC, I don't think that there should be any second thought of using ceftazidime avibactam. This is the only best choice available. However, if it is metallo-beta-lactamase, it no need to be given. It can be avoided. However, in India, we do see majority of them are metallo-beta-lactamase. What we do is we combine ceftazidime avibactam with aztreonam, and it seems to be working very well, off-label use. Now, I would like to show another interesting aspect of antimicrobial stewardship, how effectively ceftazidime avibactam can be given for a maximum benefit. Look at this paper. They have given, instead of 2-hour infusion, they have given 3-hour infusion. So with the 3-hour infusion, definitely 15 to 20% advantage in the survival rate they have seen. You can see here, there is definitely 15 to 20% advantage of survival is there when you extend from 2 hours to 3-hour infusion. I would like to have a word from Dr. Tobias and Asok with their experience of using ceftazidime avibactam for ventilated associated pneumonia, because Dr. Asok has shown the case history where ventilated associated pneumonia, what he likes to give. So Dr. Tobias?
Well, in Europe, Klebsiella pneumonia is one of the major etiologies for nosocomial pneumonia, and OXA48 Klebsiella pneumonia, mainly in Spain, in Italy, is one of the big problems. And ceftazidime avibactam is very effective in these OXA48 producing strains, as you showed. What I find very interesting, and this is something we also do, is prolonged infusion. One of my first papers in 1990 was prolonged infusion for ceftazidime, and we 30 years ago we showed that this increases the concentration and the efficiency of the drug. So in my mind, even it's not approved, it's a very, very good possibility to make a good drug, and ceftazidime avibactam is a good drug to make a good drug better.
Yeah.
Yes, Dr. Tobias, I totally agree with you. Now it's almost becoming a thumb rule that whenever you give beta-lactam and beta-lactamase inhibitor, it's if you have a provision to extend the infusion, you do that, you get a rich benefit from that extended infusion. Not only for ceftazidime avibactam, for almost most of the beta-lactams and beta-lactamase inhibitor combination, it seems that that is the standard care henceforth. But more and more evidence-based support is required. But as of now, it looks that is the way forward.
I absolutely agree. We also do it for the carbapenems now, mainly for the meropenem with a 4-hour infusion. And altogether, we were able to show that we have a drop down in resistance rates after we introduced this prolonged infusion strategy.
Yes, optimum dosage definitely will overcome the mutation prevention window.
Yeah.
Totally agree. Excellent.
I-
Dr. Asok, would
Yeah.
you like to say?
Yeah, we have used quite a bit of ceftazidime avibactam for pneumonia. And there's also been treatment recommendations in this regard. But I think I just wanted to caution the audience about the fact that when you're using it in settings of pneumonia, be careful, because there's also been resistance that's been documented to ceftazidime avibactam when you don't dose it properly, especially in the setting of pneumonia and when there's renal replacement therapy. So in those regards, I think that's best when you get stewardship or TDM, therapeutic drug monitoring, which a lot of settings we don't have. So you just have to make sure that you follow through the patient who might be critically ill and having a very septic picture and quite a dynamic renal function, to be very careful in how you're dosing the ceftazidime avibactam so that you don't have clinical failure or drug resistance.
Ashok, I have an.
I want to add one comment. You always have to have in mind that beta-lactam antibiotics are very, very safe. And if you overdose it, it's not so critical as if you underdose it. And so I'm in line what has been said. It's important to be higher with the dosage in the beginning than to be too low. And the kidney failure patients are a real problem because very often they are underdosed.
Thank you, Dr. Tobias. I have a last question for Dr. Ashok. In Singapore, I can learn that you don't use colistin. Can I know how you manage difficult to treat Pseudomonas aeruginosa when it is resistant to carbapenem? Because it is an enzyme, but carbapenem mainly operates its resistance through porine deflux. How do you manage?
Yeah, so we have, we used to have ceftolozone tazobactam. That's out of commission for a while. I don't know when that's going to be resuscitated, so that's an option for us. We can also use ceftazidime avibactam, but like you said, it also depends on the mechanism of resistance. But sometimes there are other ways in which we can circumvent this. If we use certain types of combination antimicrobial therapies by way of checkerboard testings, and so these are other ways in the laboratory that we can actually get meaningful outcomes if we use it in that way, without having to resort to colistin and polymyxin B.
Wow. So there is an indication there. Okay, fine. Now we are running out of time. I would like to move on to the live question and answer session. We wish audience to ask questions to the expert panels. I do have an excellent question here posted by the audience. So let me read that one. Local ecology is also a function of baseline antibiotic use. So which is chicken and which is the egg? Could having an antibiogram after the institution of antibiotics prompt the prescriber to use broad spectrum antibiotic at the start? So it's a very practical challenge we face. So I would like to invite Dr. Tobias and Ashok for their comments.
Well, there's no question that there are local differences. However, we have to target our treatment. We need, and it was by Dr. Asok very, very nice presented, we need faster and better diagnosis and have to target our treatment. And what has not been discussed, but I am in favor of, is de-escalation treatment. So we should start broad, but when we have the microbiological results back, we can be more targeted and drop down the broadness of the treatment.
Yeah,
Thank you, Doctor.
I agree, and I think that it's we have to educate our prescribers as well, because we're already in this mess that we are in. Can I leave you with two clinical pearls? Can I show my slide?
We are running out of time, Dr. Ashok. Can you quickly finish?
These are just two. One is that, for microbiological resolution lags behind clinical resolution. So for pneumonia, temperature and hypoxia tends to get better before WBC. So we don't have to keep giving antibiotics for so long. And the second pearl is that tracheal colonization is frequent in the second week. And so when people see that, they tend to want to chase after all these organisms as well. And so please bear that in mind.
Excellent, Dr. Ashok. Okay, so I would like to close the session. Thank you very much, Dr. Tobias and Dr. Ashok, for an excellent presentation and discussion. Before closing this, I would like audience to give their feedback either through the QR code or through the chat box. Sorry, the pop-up, the link which comes through the chat box. Thank you. I would, at the last, not the least, I would like to thank the Pfizer for organizing such an excellent symposium of the need of the hour topic, that is multi-drug resistant organism management. Thank you one and all for your patient listening. Thank you very much.
Thank you.